When somebody's life is on the line, you do not have time to stop and go, what do I do next? All right, that's how people die, is through hesitation. So today we're going to teach you that framework and that process of the March trauma assessment. What's up, everybody? My name is Joe with 0 Hour Med Solutions, and today we're going to talk about that March trauma assessment. We're going to break down what that stress process looks like, why we have a process that is systematic, repeatable, that we can follow, and then we're going to break down each step in March and just give you those high-level overviews of what the assessments and those interventions are going to look like, and hopefully this will give you a guide into some of the basic gear you need to have. When we're breaking down the March trauma assessment today, we're breaking it down in a way for normal, everyday individual civilians, right? You don't have to be a paramedic, you don't have to be an ER doctor, you don't have to be a combat medic or corpsman, okay? We're gonna break this down into what normal people can do every single day to bridge that gap from the point of injury to the time they can get to first responders or that definitive level of medical care. A lot of people want to go take a first aid class and be like, I am a surgeon. You know, if you ever seen that meme where the guy's freaking out, talking to Dr. Hong or whatever his name is, right? I am a surgeon. We are not replacing medical providers, okay? We're not replacing first responders. We should always call them and get them in route as soon as we can and then turn over a patient as soon as you can, all right? But there's a lot of things that can kill them before they get there. For instance, if you have an arterial bleed, a life-threatening bleed, that can kill you in 3 to 5 minutes. It happens very quickly. So that's why we need a process and to know the skills, tools, and interventions that go with each process so we can bridge that gap. So what does MARCH stand for of the March Trauma Assessment? It's simply an acronym that stands for massive hemorrhage, airway, respiratory, circulation, head trauma, and hypothermia. It's a systematic process. It's not just a theory. It's a proven framework that's used around the world, used within the military, and used by a lot of different entities around the world every single day. And it's proven in trauma to address those life-threatening injuries. And we know it works because it has been happening for years. I was in the military for 10 years as a Navy hospital corpsman. 8 of those years greenside with the Marine Corps. I've used that process anytime I encountered patients, and it has worked. It saves lives. I know it works, all right? So that's why it's so critical, and we're gonna go over it today. The reason we have the March Trauma Assessment, and that's what we use, is because it gives us just a framework, that process to work through, because most people don't rise to the occasion. A lot of times they fall down to their lowest level of training, and that's why getting the training and knowing a process is crucial to have in your back pocket. Whenever people get into that life-threatening situation, whether it's self-defense, whether it's an accident, whether your loved one's hurt on the ground, bleeding out all over the place, your body is going to activate that sympathetic nervous system, dump a lot of adrenaline, and whenever that adrenaline hits, your brain's going to go into processing overload, all right? It's going to almost half shut down. It can cause time distortion. It can cause tunnel vision, right, where you get sucked into one thing. That's exactly why we have the March Trauma Assessment, to keep us from getting sucked in. So we ensure we're assessing and treating everything head to toe, and we're actually not missing anything or any secondary injuries that can kill them. And then you also tend, whenever that sympathetic nervous system kicks in, you tend to lose your fine tactile motor skills. You go into gross motor function, right? That fight or flight response. Your blood and your oxygen is trying to get to your muscles, right? It's trying to get you stronger, get you pumped up so you can either fight harder or run faster. And so having this process to fall back on helps alleviate some of that stress. And knowing a process like the March Trauma Assessment, having the skills, knowledge, training, and tools behind it, it builds confidence in crisis. And that is the key of this video. And what we do here at 0 Hour Med is help give that to people and everyday normal individuals, law enforcement, or whoever just wants to get training. If you're a range goer, you know, you're a 2A kind of person, you're a prepper, it doesn't matter. Everybody should know how to sustain life or bridge that gap to buy time to get them to that next level of care. Let's get into M of the March Trauma Assessment. That stands for massive hemorrhaging. The key here is to very quickly identify any life-threatening bleeds, such as an artery that is severed, right? Because those are your high pressure, high volume lines. When they get severed, you pump out blood very, very quickly. And how we're going to identify a life-threatening bleed is through our blood sweeps. That's our assessment for M. So whenever you roll up on somebody, start your blood sweeps. So that's going to be visually inspecting them. Do I see any massive hemorrhaging? If you do, go address it. But then we have to make sure we go physically assess those extremities and junctional areas. So we're going to be touching those areas and visually inspecting them. Junctional areas are just going to be anywhere where you have an extremity meeting the core of your body. So my head meets the body at my neck, my arms meet the body at my shoulder, armpit, and then my legs meet the body at my pelvic region. So those are the areas we're performing blood sweeps. We're performing a physical sweep with our hands and a visual assessment looking for any blood as well. If we find any blood, then we need to apply one of our interventions, which we'll get to here in just a second. So those junctional areas I just listed off, those are just areas that are not anatomically amenable for a tourniquet, all right? So that simply means you cannot apply it per the manufacturer's instructions. You cannot wrap it around like a limb, like an arm or leg, where you can provide that 360 circumference like you need to compress that tissue and that vasculature to stop those bleeds, right? They're usually too large of areas, or usually there's bones, joints, there's something there that keeps you from being able to get the proper compression with the tourniquet. So we're gonna use that wound packing gauze. When we're doing those blood sweeps, we're looking for 4 key identifiers to let us know that it is probably a life-threatening bleed. What we're looking for is bright red blood, spurting blood, enough blood that is saturating or soaking through clothing, and blood that is pooling on the ground. If they have any one of those 4 identifiers, we know it's probably a life-threatening bleed, and we need to address it and stop it now. The spurting or bright red means that's probably an arterial line, all right? That bright red color comes from the hemoglobin and the oxygen when they bind in the bloodstream, gives it a nice lively red color. So that's how we know it's an artery, because it's very, very richly oxygenated blood, and it's going from your heart through your arteries out to your body. Those are those high pressure, high volume lines. When we're talking about either saturating through clothing, where you can wring it out like a wet wash rag, or pooling on the ground, that's just going to tell you that it's probably enough of a high volume of blood that this is going to be life-threatening very, very quickly. All right, so that just tells you volume. We see a lot, we need to stop it. Our interventions for massive hemorrhage are going to be things like tourniquets on extremities. We have hemostatic and non-hemostatic, just regular wound packing gauze for those junctional areas. And we also have things like pressure bandages, or we can use our hands for direct manual pressure. All these interventions are very easy to apply, but they're also super easy to mess up. And that's why you need to get training and learn how to do these things appropriately. All right, so let's talk about the A for Airway of the March Trauma Assessment. Airway is going to be either very simple or it's going to be a little bit more complicated, but either way, it's not too hard, especially for those non-medical people. There's only so many things we can do, so that's all we're going to talk about today. So Airway, if they are awake and screaming at you, and you can articulate, what's going on, they're telling you where they're hit, it hurts a lot, just yelling in general. So if they're talking, we know they're breathing, we know they have an open airway, and so easy day, we move on to the R, that 3rd step in March. What do we do if they're unconscious, they're not talking to us? We just hear silence, okay? That just means we need to get into our assessment interventions a little bit deeper for airway. How we're gonna assess that airway is we're gonna perform one of 2 manual airway maneuvers. So we have our head tilt chin lift or our jaw thrust. Those 2 airway maneuvers are simply just a process to open that airway, align those airway structures so they have a better, more direct, clear path for air to move in and out. And it allows us to open that mouth and visualize the inside of that oral airway, all right? So what we're looking at in there is, do we see any foreign objects? Do we see broken teeth? Do we see a tongue bit off? Do we see rocks, dirt? Do we see anything that doesn't belong that can potentially cause an airway obstruction? And then we are clearing it. We also are looking for liquid obstructions. So are they gurgling? Are they vomiting? Is there blood in their mouth? If there is, we need to clear it. So how do we clear liquid objects? Most people aren't going to have a suction device on them, all right? You're not an ER doctor, you're not a paramedic on a rig, you're not an EMT, right? You usually aren't going to carry suction with you. And if you do, good for you. You have a lot more money than I do to be able to just go buy a suction machine and carry that around at will with you, all right? So that's why we use gravity to clear those liquid obstructions or things that could potentially cause somebody to aspirate and inhale that fluid into their lungs, which just increases breathing issues even further. For solid objects, it's very, very simple. All we're going to do is do a finger sweep or just grab it and pull it out of their mouth if we see it, all right? Now, we do not blind finger sweep, all right? You don't go in there and just dig around in their mouth, all right? And then if we see something but it's lodged very far back in the airway, we're not going to go in there and try to grab it unless we are positive that we can get it, because we don't want to actually bump it or shove it farther down the airway and cause a full-on obstruction, all right? Because if you can see the mouth, it's probably not down in that lower airway yet, and it may be causing a partial obstruction, but maybe not a full obstruction, okay? So we don't want to make that worse and cause it to become a full obstruction. For interventions for airway, we have things like an MPA. which is a nasopharyngeal airway. That's an awesome tool. It's just a little hollow, kind of basically straw or tube that you insert into that nasal passage, and it goes down and bypasses the back of the throat, because when people are unconscious, their muscles relax, and then muscles relax, that tongue likes to fall back and block the back of their throat, which can cause breathing issues. So all this does is that nasopharyngeal airway goes down the back of that nasal passage and bypasses that and ensures that we have a patent clear airway. Airway is one of those things we really have to reassess the status on, because if we do have a patient that is awake and screaming, and then we continue on because we know the airway is open, but at some point they go unconscious, and when it's like, oh, it's real quiet all of a sudden, it's real silent and weird. Cool, go back and reassess that airway, okay? Because remember, that is before R, but this is before C, is before H. So if we're on any of those other steps, because we didn't have to worry about airway because they were screaming, you immediately go back, reassess, and work through those interventions and assessments I just told you, such as manual airway maneuvers, clearing the airway, and etc. Respiratory. Respiratory is that third step of the March trauma assessment, and all that's talking about is where the oxygen goes into your lungs in that chest cavity, and do you have any penetrating chest trauma? Do you have a tension pneumothorax? What is going on? Are they actually able to breathe, or are they breathing? All right. And if there's any penetrating trauma, we need to seal it. All right. And when we're talking about that chest cavity, we're referring to what I call the box. So if you think about that collarbone down to roughly that belly button or that navel, on that space, that 360 circumference all around their body. So front of their chest, their sides, and their back, that is what I'm referring to as the box. Your assessment for respiratory is going to be what I call those tiger claws. You put your fingers together, you get your trauma shears, expose that entire box all the way around. You're visually inspecting for penetrating chest trauma, and then you are tiger clawing, all right? So you're visually inspecting and physically feeling those spaces. And if you find any type of holes or penetrating chest trauma, you're going to seal that with a chest seal. One thing people miss a lot whenever they get to R of March is a lot of people may see an entry wound, but what might be accompanied with that is an exit wound, all right? And even if you don't see an entry wound on the front, the entry wound could be on the back, all right? I always say, don't run away. I say I'm not gonna get shot in the back, but you never know when somebody's situation is gonna be, all right? So make sure we are checking everything. When we go in there and seal it, we wanna use vented chest seals. Vented chest seals are an awesome tool because it allows us to seal any type of penetrating trauma we may find all the way around that box area. And then when we seal it, it has a one-way valve, and so that way air can't come into that chest cavity and create a tension pneumothorax or other issues, but it may potentially, depending on the injury set and the wound channel and everything like that, and the skin and everything, it may allow air to be expelled through that chest seal and potentially alleviate tension pneumothorax, but at the minimum, hopefully it will stop it from progressing as fast as it normally would, or progressing at all, hopefully, if you get there early enough. All right, let's talk about circulation. So for non-medical people, circulation is going to be more of that diagnostic administrative phase, because we did massive hemorrhage, airway, and respiratory. So we already kind of bought that time we needed and treated those initial life-threatening injuries. So now we're worried about those things like pulses, are they into shock, getting more of that diagnostic information that we can communicate and pass along to either first responders, 911, if we're taking them to the hospital, right, communicating to doctors, that receiving team at the facility. But we want to look at things like the pulse. So when we're in circulation, I'm gonna start with my radial pulse. Use your first two fingers, never your thumb, because your thumb has its own pulse. First two fingers on that thumb side of their wrist, you're looking for a pulse, and I need to know three different things about that pulse. I need to know the presence, so do they have that pulse or not? I need to know the rate, is it very, very fast or very, very slow? And then I need to know the quality, is it a weak pulse or is it a strong pulse? Because that's going to tell a medical provider kind of a lot about what's going on, what stage of shock they're probably in, are they compensating, are they not compensating? But that's good diagnostic information to have, document, and pass along. If they don't have a radial pulse, cool, move on to that carotid pulse. And if they don't have a carotid pulse, that's a really bad day. Get medical help as soon as you can, because it's probably out of your realm of being able to assist at this point, all right? But we're start with that radial pulse. If they have it and you can get that data and document it, cool, no need to go check that carotid. We're gonna move on and we're gonna do some reassessments. Circulation is a great time for reassessments because, again, like I said, it's more that diagnostic phase. And also, what do we do if we rolled that patient for airway to clear some type of fluid? We rolled them, so we should immediately reassess in airway after we moved them. If we were in respiratory and we rolled that patient to check the back of that box to find any penetrating chest trauma and seal it, we rolled them back, Guess what we did? We conducted a patient movement. So anytime you move your patient, the first thing you immediately do is reassess. In circulation, you probably don't have a movement, but again, this is a great time to go ahead and reassess all your interventions, especially for those life-threatening injuries. Make sure they are still patent, they are working, and they are holding, right? Reassess the airway, check that status again, make sure you know what's going on with your patients, and document. Head trauma and hypothermia, all right? Head trauma is going to be a hard one depending on what's going on. Because if your brain's hanging out, we're not doing anything. Medical people outside the hospital aren't going to really do anything for that, okay? So for head trauma, if you see a laceration or something like that, get a big bulky dressings, lightly secure it. But the biggest thing here is not to touch with any kind of pinpoint pressure like your fingers. When you use the palm of our hands, work around that head very lightly. We're going to see if, is that skull compromised? Is there any obvious fractures that we can document or relay that information along to first responders, right? And or protect that area as much as we can, all right? Because if you have a brain fracture and your skull is compromised, that can potentially penetrate if you push bone shards in the brain and kill them, cause irreversible brain damage, and increase intracranial pressure, a lot of bad things that can kill them. So be careful when it comes to head. Only act and work confidently if you know what you're doing and you are trained with the head. For head trauma, we can also look at mental status, okay? So did they hit their head? Did they go unconscious? Did they lose consciousness? If they did, or just in general, we want to assess that level of consciousness. We can do things like AVPU, so that's just an acronym. We'll make a video about it later on, kind of how they conduct that assessment. But it's pretty much just a way to assess their mental status. And again, we want to know that, document that information, and pass it along to first responders or that definitive medical facility. Last but not least, hypothermia. This is one of the most important ones that I think a lot of people don't actually understand that well. So hypothermia, it does not matter if it's 100 degrees out in Oklahoma in the middle of the summer. You can have somebody go hypothermic very, very quickly. A reason for that is because if somebody loses a lot of blood because they had a massive hemorrhage or something like that, then they're losing a lot of their ability to regulate their core temperature, all right? So your core temperature only sits at 98.6 degrees is the average. You hit 95 degrees and below that, that's considered hypothermic. When you go below 95 degrees, you're losing a lot of your body's ability to clot, all right? So we call this coagulopathy. So that means there's something going on in the body, such as shock, or if they took medications, they were drunk driving and their system was full of alcohol, right? There's a lot of different reasons somebody can be coagulopathic. Again, which just means you have inhibited clotting abilities in your body, but that can make people die so quickly. So again, even if it's the summer, we need to check and make sure they're not hypothermic, right? So if we see them shivering or they look like they're in shock and they're pale or kind of gray, they have altered level of consciousness, they're kind of mumbling and stumbling, they're dizzy, anything. There's a lot of different things we can look at here, right? But if they have any one of those, or they did lose a lot of blood, regardless if they are exhibiting any of those signs, which they will exhibit something, right, if they lost enough blood. But we're gonna go ahead and treat for hypothermia because the key here is prevention. All right, because treating hypothermia pre-hospital is extremely hard to do, all right? So we are going to prevent, we're gonna get something like that Mylar space blanket, those shiny little blankets, wrap them around it because it's non-permeable. It doesn't allow moisture, water, air, wind, anything in or out, and it reflects a lot of that heat and reflects it back to the core and helps regulate that temperature so they don't go hypothermic, which will lead to coagulopathy, and then hit that lethal triad and that cascading effect. Acidosis and everything will kick in, which is just a bad day. If you want to learn more about the lethal triad shock, stay tuned and we will make a video for that specifically coming up here soon. All right, so that was just a quick rundown of the March trauma assessment. And so hopefully that gave you a kind of idea of why we use it with that, sympathetic nervous system and how the stress hits, why it's important to have a process and get training so that you can build that confidence in crisis. Or hopefully now you know what kind of tools you might need and need to go train with. So our tools, again, right, that cover the March trauma assessment are going to be tourniquets, wound packing gauze, hemostatic gauze, pressure bandages, knowing how to apply correct direct manual pressure, how to do airway maneuvers, how to use chest seals, how to use space blankets, right? These are all key things that you need to have. Trauma shears are awesome. You also can get a March quick reference card for free on our website, linked in the description below. These are awesome. They fit in your IFAC, and they just give you pretty much a guide of how to walk through the basic assessments, what you're trying to identify, and what your interventions are for each step, all right? But again, I hope you learned something from this video, and if you did, let me know in the comments below what you learned was new. And our goal here is to explain that March trauma assessment so normal, everyday people can understand it and apply it, because it is applicable. You do not have to be a combat medic. You do not have to be a corpsman, paramedic, EMT, a doctor to do March trauma assessment and buy precious time to save lives until we can get that patient to that next level of care. Get the training, get the gear, build that confidence in crisis, be prepared, be confident, and save lives every day. Thanks again. This is Joe with 0 Hour Med Solutions, and I'll see you in the next video.